recording now.
Okay.
So hi everybody again. Thank you for coming back. We have another guest speaker for this week. This is Connie Haselden. And
Hello.
I have asked Connie to join us so she could talk a little bit about some of the how health equity is operationalized in the delivery of public health. And I'm going to ask Connie to introduce herself and how she is able to speak on this topic, and then we'll go through a few questions. So Connie,
Okay,
take it away.
Thanks, Andrea. Hi, my name's Connie Haselden. I work for Island Health Authority, which is located on Vancouver Island in British Columbia. Currently I'm working as a manager of the primary care networks, but immediately prior to this position, I had been managing public health in South Island in Victoria. That program involved managing health units as well as multiple programs, including speech language, dental and audiology, mainly for children and youth and their families up until the age of 19. So that is my background for the last few years.
And your also background is in nursing.
Yes,
And
that's right.
so many of the students in this course also have backgrounds in nursing, but it's pretty diverse range. People who are working as community organizers, people who are working social activists, so our conversation around equity is really relevant for time right now, and just talking about how it comes from policy initiatives and maybe reaches the ground or maybe it doesn't. And so I wanted to ask our first question about how do you see public health being able to address health equity on the ground?
Okay. Well, health equity is a really big deal in public health, and it's championed certainly by our medical health officer in Island Health. That's Dr. Richard Stanwyck. So, and maybe some of you have read articles he's written or have been able to see him interviewed on the media. And it was always, I think public health is always being public service. You're trying to reach the maximum number of individuals with I guess the best standard that you can provide for all of those people. Sometimes that doesn't mean that individuals are going to be seen immediately or when they want to be seen, because again, you're trying to triage, ensure that, for example, speech language, children that are most affected and most needy, and most importantly, about to start kindergarten, are going to be seen first as the most urgent. At the same time, other parents who have children that maybe have a speech impediment and they've been waiting months for therapy, and their needs are equally important. So looking at what you can do in situations like that, it is a bit of a dance, attempting to see all of your individuals that have the highest care needs first while developing programs for others while they're waiting, for example. So in the case of speech therapy, we would have family, sort of like a group therapy session where children could be seen. There were definite lesson plans, so maybe 6 modules, and each week or every couple of weeks, parents would attend with their child, go through these modules, but there would be maybe 6 families with a speech pathologist instead of that one-to-one. And that was a way to really try to extend the reach of one person so that more people would be able to benefit from those services. Some of the other ways that public health really addresses equity as well is just our immunization programs. So they're open to all individuals, and most importantly, and a lot of people don't know this, you don't need an MSP number to come to a public health unit. So you could be someone who is new to this country, who has come here from another country, a little less likely during COVID times, and you come in with your child and you would like that child to be immunized. The nurses there are going going to set up an appointment for you and arrange for that to happen. I can't really think of any other instances in our healthcare system where you would not need to be registered with the medical services plan in order to, and have a PHN number in order to receive services. So it's very universal and it's global, and it really doesn't depend on individuals meeting certain criteria. It's open to absolutely everyone. Having said that, I think that, as with many health services, the whole idea of universality has really been modified in past years. So people, perhaps in the past, if you had a baby, a nurse would always come and see you at your home, see how you were doing, maybe give those immunizations, but also support the mother with breastfeeding and or infant feeding, and support, do the assessment for postpartum depression and support that way. So now, I think the wisdom had been, well, you know, we're going to perhaps target our one-to-one services to those that may be more vulnerable. And a few years ago, a plan was developed. It's called Right from the Start, and people could register for this when they were expecting, actually. And the idea was that those people that were most in need, and it was kind of a letter system, you know, like A, B, C, D, etc. So if you maybe didn't have good family supports, if you didn't have higher education, if you didn't have a computer and couldn't easily look up information, then you were considered a bit more vulnerable. And therefore, you would be, I guess, slated to have a little bit more attention. What we found with this program after a number of years is we still ran some universal programs, things like, well, there was one program called Baby Talk. Anybody could sign up for that. So if you were a mom, it didn't matter if you were from a wealthier socioeconomic group or if you were from a more vulnerable group, anybody could sign up for this. And I think the class size pre-COVID times was about 20. You came with your baby, and you could come for, I think up to 12 weeks, and there would always be a nurse there facilitating and sharing information and opening up the floor to questions. And what the nurses were finding is that even though individuals would be coming who would not necessarily have met the vulnerability criteria on the Right from the Start assessment, that I mean, maybe they had great supports. They were well educated. They had a computer. They were very literate with social media and any kind of information seeking. But they perhaps presented as somewhat depressed or struggling. And this was never something that was going to be identified through the assessment process that we had set up. It was only identified when the nurse was able to lay eyes on someone that she might not otherwise have been able to see. So I think that the great thing about public health and why public health nurses really value their roles is that it does allow them to certainly focus on those who are identified as most vulnerable, but it's universal enough in terms of everyone can have an immunization, anybody can sign up for some of these parenting courses, that anyone can be identified and kind of picked up and seen as possibly requiring a bit more assistance or help, and asking if that's something that they would wish to have. And if they're saying yes, absolutely, then we can connect them with those community resources as needed.
That's really, I really appreciate that too, because with the conversations that we're having around equality, equity, and justice, this this understanding of equality is suggesting that people are all starting from the same spot, and we know that that's not true. That there's potentially barriers to accessing care, but what you're talking about here with this universality in this program is actually removing those barriers for everyone. And so even though we're recognizing that we may not all be starting from the same spot, the barrier to access means that everybody has access to it equally in ways that may be culturally safe and culturally appropriate, but that you're still honoring that individuals' right to health in a way that makes sense for them.
Absolutely. And you don't want to stigmatize people, right? So we have other targeted programs which are especially developed for individuals who may have issues with, food insecurity, income insecurity, intimate partner violence. So you come to these places because you've sort of filled out the application, and now you're going to get some vouchers for food and for transportation and bus passes and etc. But if they're located in a place where anybody would go, then nobody really knows that that's why you're going to that place. And I'm thinking of in Victoria, in one case, it was like a house where you actually had to go up the front steps and wait at the front door, which was locked, until someone let you in. And meanwhile, everybody who was passing by would know that that was that kind of place and you were going there because you were poor. Contrast with another place which was located next to a mall. It's actually in the mall, next to the library, next to the rec center, where you can go in there. Nobody knows why you're going in there. I mean, sure, you're going in to have a terrific program, to have a meal with your child, and the community prep meals were great because a lot of moms and older kids would be in the kitchen with a dietitian and they'd be prepping up a meal. Maybe you'd have 3 or 4 meals in those foil containers that you could take home with your family. So these are ways to, I think, enable and assist those that may need that, but nobody knows why you're there, right? Now, that was not a universal program, but I think the location of it really respected that everyone who goes to that mall or goes to that parking lot or gets off a bus there, you don't know why they're going there. You could just be going to the library. Same with our lunch programs. Certainly some of our schools in districts that have been more vulnerable with lower socioeconomic families, those meal programs, because it's breakfast and lunch, are open to everyone in that school. You don't have to qualify. You don't have to complete an application. Nobody is going to target that child and say, oh, well, if you have to go and be a part of that lunch program, it must mean that your family can afford to ensure that you have a nutritious breakfast and lunch. And we know that's so necessary for growing bodies. No, anybody can go. And I think that as we're working to provide, even for the most vulnerable, we have to do it in a way that keeps it on the level so that it isn't, they're not stigmatized and they're not singled out because of, especially in the case of children, something that is entirely not their fault.
Mm-hmm. Yeah, no, that's so wonderful. What I'm thinking about though here is that when you're talking about public health response to issues around food security and around health and safety, particularly capacity building in schools, that does make me think a little bit about the cross-jurisdictional challenges that you might have. And even though there's cooperation with, say, the school board or perhaps some other areas, is there a burden that's placed on public health to respond to needs that are outside of the scope of practice of some of the nurses? Is there a way that gets responded to? I'm thinking, for example, when the refugees, the Syrian refugees families were came to Victoria, and the way that public health responded to that, but the complex needs that were involved there weren't. The resources were not necessarily all available to public health to respond to them all, and yet you did.
Well, yeah, that absolutely happens. The Syrian refugees came in February of 2016, and public health did respond. We set up clinics at the hotel. We actually were going to try and do everything that needed to be done at the individual clinics, but transportation was going to be a bit of a nightmare. The Red Cross was already in the hotel, so we were able to access Red Cross for translation. Most of the individuals there spoke Arabic, and there's very few Arabic-speaking people in Victoria. A few, but not too many. That was not something that public health had been trained to do. Certainly immunizations, yes, and when refugees come to this country, that is something that has to happen within the first couple of weeks. They need a full health assessment. If they haven't been immunized, they require up-to-date immunizations. But you can imagine that people who have been living in camps for the last couple of years, especially children, have many, many other needs besides those. So public health is targeted for that immunization piece, but it just ended up being a much broader kind of service provision. And absolutely, we weren't able to do everything ourselves, but then we contact our local laboratory services. We get a hotel room and we get them to set up a lab so that they can do blood draws. We had nurse practitioners and GPs from every area volunteering to do shifts where they could do the complete physical assessments for those individuals. And we learned so much in working with these individuals. Also, we had our dietitians involved because of course, we wanted to make appropriate food items for everyone there, and especially for young children. Like mothers didn't have formula for their babies, or perhaps the nutrition that they needed for their children, so they had brought a lot with them, but that wasn't going to work. And we'd had pharmacists on call because, again, people have medical needs and pharmaceutical needs, and you're coming to this new country now. Everything has to be addressed, and it has to be addressed in a different way. And you're working with a population that is highly traumatized, highly anxious. I think in Damascus during the crisis there, you don't respond when somebody knocks at your door because that's never really a good thing. So we discovered that going to people's hotel rooms and knocking on the door to say, can you come down and have your lab test, or can you come and have your physical assessment now, or now is now a good time to do the immunizations? Yeah, people aren't going to answer the door. So we had to figure out another, how else are you going to provide information for people that's safe and that respects where they're at. And unless you have been there, it's a little unbelievable to imagine what people have survived and lived through, and to think they're still walking around and speaking and caring for each other is pretty amazing. And I think, of course, Andrea was a little bit involved in that too. One of the things that we found, what do people do? I mean, in homes where, in homes in that part of the world, a majority Muslim, men and women don't congregate together. Women congregate separately. So a lot of women were staying in their hotel rooms while the men would go and have their meals. And by the way, French fries was a great favorite. Not very healthy, but it was a huge favorite. But the women were such great handcrafters, so knitting and crochet and weaving. And once we knew this, and we would just get everyone to donate wool and find knitting needles. And I think my mother had like a bundle of knitting needles like that, which I brought. And I'm a terrible knitter. Andrea's a good knitter. And yes, my mother was saying from up above, give away the needles. You can't knit, so let somebody else have those. So these women would overnight turn out like slippers and little baby dresses. And it just gave people a purpose, and in the midst of this really terrible time. So I think public health did all of that in terms of, we got to be flexible and adaptable and able to deal with ambiguity and figure out, like, what are you going to do when somebody has to go to the hospital, and it's usually most of the paramedics are men, and they have got to examine that woman. And I think they had a conference about this, actually. Yep, okay, for this purpose, if it's an emergency, if her life is at risk, it's okay. He can listen to her chest. So again, you're providing for large groups of individuals and doing things that you normally don't do. Earlier this year, because we were part of the COVID testing in Victoria, setting up the drive-through COVID testing sites, but then asked to participate in testing individuals who are living in our homeless camps. And again, not something that public health normally gets involved in, but we did it. And people who felt comfortable with working with street people would go in teams and test individuals that required it.
And well, that's interesting you say that. And can you speak a little to then, what about those individuals who were not comfortable with that? And when there's roles and responsibilities that are required in a job, and there may be some things that some individuals, values that individuals are reconciling for themselves, were there certain measures that were put in place that needed to address that because the urgency of the need required staffing at a certain level? Was that something that was important to address, or was it something that you had to make sure that everybody would feel safe staff and clients
Well, number one, we
alike.
want to make sure everyone feels safe. And also to remember is that all of our nurses are unionized, right? So we have a collective agreement that governs their work environment and their work situation. So when you're doing things that are a little outside the norm, you ask for volunteers. Who is going to feel comfortable doing this? So who has the capacity and competence to perform the actual task, but also who feels comfortable doing this? And not everyone did. I mean, certainly even now with COVID testing, if you are a nurse and you're over the age of 60, if you are living with someone that's immunocompromised, you're not required to do this work. You can apply to do the work. And if you are an older individual, you would know that okay, you accept that risk because if you're over 60, you're at a greater risk. But again, there's never going to be an individual that is going to be forced into performing a task that is not, that's a little unusual or not something that they're comfortable doing. And that's with anything, even if it wasn't for COVID or if we didn't have street people or Syrian refugees, even on a day-to-day basis, you are really trying to match your employees to.
Wait.
So. Mm-hmm.
Oh, okay, sorry. The sound blocked out for just a moment there. Can you repeat
Okay.
that just in case it blocked out for anybody else that you're
Oh,
trying
sure.
to match?
I was going to say, whatever you're doing as an employee, you are going, I mean, there is a job that you apply for and there's a job description, and we try and stick as much as possible to the job description. And some of those job descriptions are deliberately a little vague because, you know, we add things like and other related duties, right? But we're not going to ask someone who's really uncomfortable working with a certain population or working or delivering a task or performing a procedure that is very uncomfortable for them or that might be triggering for them, because our roles as employers for sure is to keep people safe in their work environment.
Well, and that makes me think of, well, one of the weeks that we had was also a discussion around cultural safety and cultural safety and care. And sometimes what can happen is that it can be the service provider that may inadvertently, unintentionally, or intentionally perhaps create an unsafe environment that discourages folks from accessing care. But one of the important pieces is around capacity building in cultural safety, and especially right now when we're talking about cultural competency quite a lot as well. One of the readings for this week that I told you about discusses ensuring that health equity is a conversation that is had at the very top levels, around those senior management levels, and that equity is part of the policy framework, and not just as a value, but also in something that is integrated in language, in resources, and as a priority. And I wondered if you could maybe speak a little bit to that as well, about the effectiveness of having those conversations at those top levels when the work is happening on the ground, and is there an ability to make sure that there is that connection between those upstream decision makers and those downstream care providers?
Right. Well, I've never believed that real change happens at those top levels. And a very wise educator once said that an organization's vision is what you really hope is going to happen in terms of your service provision, but your values are what's really happening. And sometimes our values are not congruent with that vision. And I think that real change has to come from the bottom up. I feel that every individual that's going out there in the community that's working with a patient or a client has to have that understanding. Now, one thing I will say about Island Health is that we take, for example, that cultural sensitivity very seriously, and cultural humility. So it is mandated that everyone that's joining the organization have a basic program or course in cultural sensitivity around our Indigenous population. And we have other courses as well that build on that initial foundational course. But we want everyone to know that people are not the same. And with respect especially to our Indigenous communities and partners, I think our premier the other day on a debate was saying, well, I never saw the difference. You know, everybody was all the same. And I think sometimes people say that, and they say it as a way to I guess, appear that they're not racist and that they don't, that for them, a person's background or background experience is not going to affect how they're treated by them. And I understand that. I think that's fine and well, but quite realistically, we're not talking about the same thing when we're looking at our, especially our Indigenous patients and clients in the community. And it isn't the same. I think people must be aware of practicing with that trauma-informed lens and asking lots of questions and being a good listener. We have a program called motivational interviewing. A lot of your students, Andrea, will be familiar with it. And it really teaches exemplary listening skills, but also just that to talk back where, I heard you saying this or describing this, and is this what you meant, and just checking back. I think that's very important, and really to be meeting people where they are is just so very key. So in terms of creating that equity, people who are out there every day, meeting your patients, meeting those clients, they're the ones that are going to make that change. And they're the ones that have to have all that information and resource at their fingertips so they can move that process forward. Because up here, you can talk all you want and you can have lofty ideas that expand on what should be happening, but what you really want to see is some changes at that ground level, right? I mean, you want to see your employees who are going into the community providing home care to be acting with those values, and so they have to buy into that, and that really means having that early conversation with all of those individuals. And I would go so far as to say those individuals need to have that conversation first. I mean, so they can be the early adopters, right? And then move it up the ladder rather than down. I mean, hopefully, you're going to have a meeting here where everybody is finally on the same page. But too often, a lot of ideas are generated at the vice president, executive director, and director levels, and they really don't trickle down through what I call, it's kind of like a glass ceiling. It's supposed to get down to that managerial level, and managers like myself are supposed to disseminate to all of the staff. But I would need help doing that. And again, just providing that isn't necessarily going to be the change you want. You really have to, I think, alter how that work is done so that there's real change, and people have to believe in it. I wouldn't want an employee who's just going through the motions and saying, yeah, okay, I'm supposed to do this, so I'm going to do it, and not really believe in it. If you really don't believe in equity, if you really don't have that compassion and empathy for the people that you're working with, then maybe this really isn't the field for you to be working in.
Mm-hmm. And I think that's a fair question too. And I think that's, everybody has their gifts. Right. And I think they can, when they're channeled in the right ways, they can be productive and contribute. I think this, the consideration as far as some of the things that may be happening here, and then the other activities maybe on the other side of that ceiling. One of the comments that you had made when we were chatting earlier was around this, you're kind of swimming upstream. I think you called it the tyranny of the urgent.
That's
and
right.
having to respond to, there's the measles outbreak, and then there was the rabies, and then there was COVID. And then while these some of these complex issues are being discussed around social determinants of health and removing barriers and creating situations where there can be this social change, meanwhile COVID happened. And so what happens to those conversations? Do they have to stop or be put on hold? Or I think that response is, there's that challenge there. And
well, you're always going to have a challenge. You're always going to have a measles or a rabies or something like that. It may not be those particular things, and it may not be as
those can be bats and ducks and
all consuming as COVID. There will always be something urgent. And you're right. I mean, the tyranny of the urgent, oh my goodness, that's your priority. But I think what we're talking about really is, what's our delivery like? How is our delivery every day? right? When we're going into people's homes, when we're meeting them in our health clinics, what is that delivery like? And I think that's the part that has that, if it's going to be altered, that's the place where it's going to be altered. And I don't think that just because we've got lots of other stuff going on, that the way we're treating each other and the way we're doing our work is necessarily has to be different or worse. It should still continue to be improving and better, even despite the fact that, yeah, we got long lineups for flu shots or whatever, but each person that is coming for a service still deserves to have the best consideration as a person that they can have.
Mhm. So would then, so considering, the students that are engaged in this course, they're at the beginning perhaps of some of their
Mhm,
graduate programs, and many of
mhm.
them actually have completed graduate programs. They're professionals, they're
Well,
working, or they've come through,
congratulations.
for sure. And now, as being stewards for health equity and social justice, and social justice in the sense that we're really talking about bringing that ability to have that universal access to care. Um,
Mhm.
could you suggest maybe things that they could carry forward with them if they're thinking about getting engaged in some leadership roles in their communities?
Right. Well, first and foremost, I would say if you have an opportunity to do some shadowing with nurses that are working in the community, with nurses that are involved in providing services to our First Nations communities, take advantage of that. Like, even if you shadow just for a day, and of course, in the most respectful way possible, and asking consent and permissions, of course, it just gives you a window on where that work is going. It's great if we're developing policies and procedures at a higher level, but you really need to see what's happening at that lower level, and or at that ground level. It's not a lower level, it's really where everything's happening, where everything's
Mm,
going on, because you want what you're developing in future, and you would hope that those policies and changes that you can be party to changing are going to somehow have a great effect on the work that's going to be done. But maybe you first need to see how that work is happening now, and what are some of the challenges with doing that work. And it might just give you a bit more of a balanced lens on creation and development of how we should doing work to the actual work that's being done. So definitely, if you have an opportunity, check in with managers like myself. Can I shadow somebody a day, or go somewhere and see how things are working, and just give yourself that opportunity for sure.
mhm.
Or even, I would say, even interviewing or meeting with people like
Mhm.
nurses who are on the job, and if you could meet with them and just ask them, what's your day like in a given day, what does your day look like if you're a home care nurse and you've got multiple appointments and they're in different communities, and what are some of the challenges.
Hmm. And one of the things that's really incredible with this course is we've got a lot of those folks who are taking the class, who are doing work on the ground, who are
That's
supporting
great.
supporting initiatives in harm reduction, who are
Mhm.
working in well, all kinds of areas. And it's been really really humbling to see the kinds of work that people are doing. And then here I am sitting behind the
Mhm.
desk, and
Mhm.
um, and so I think it's maybe even hearing from yourself is just that you're in support of continuing that good work. And
Absolutely. And I'll just share something. Like, earlier this year, after we had set up our COVID drive-through sites, and after we had been expanding our practice to do more outreach, and I went down to the Topaz Park in Victoria, which was going to be like this tent city. And I'd heard about it, but I'd never been there. I've driven by it, and I see all these tents and all these people, and I don't know what sort of image I had in my mind. I guess I might have thought, well, it would be crowded, and there would be people around using drugs, and there'd be stuff all over the place, maybe garbage all over, and people being unruly. So I thought, I'm going to go there because my nurses are going there, and I need to, again, just check out their work environment and look at that safety. And what I found was a place that was quite tidy. I mean, all the tents had, a circumscribed area they were supposed to be in. There wasn't garbage all over the place, mainly because there were people that were picking it up. They just volunteered to go around and pick this up. And there was a tent here where a lot of middle-aged fellows were sitting and having a smoke and a coffee. And there was a place over here where you could get a meal, you wash your hands and you get a meal. And I think what I found was it was just so orderly. Oh, there was a whiteboard behind the meal service where these are the drugs that are out on the street that are dangerous, and they use the street names for them. And I thought, wow, that's a great public service. And I think people who live there, quite honestly, did feel like it was kind of a community. And I know that it wasn't ideal for everyone. I know there were assaults happening there in the evenings, and eventually it did need a bigger police presence. But I certainly don't think that that was the majority of the campers. So sometimes when you have a notion in your mind of what an environment is like, sometimes it's not like that.
Mhm.
So go and have a look at that environment and see if you can just walk around and with people's permission, chat with individuals. I mean, I had no trouble getting people to talk to me. People want to share their stories, and I felt very privileged to be able to hear that. And I think I came away from that feeling as though, yes, you need to be careful. It's good to go in teams. Things can still happen, but it's not as I had initially imagined. And I think that main bit of information there is just to really don't make assumptions. Go see for yourself, check it out, and yeah, come away with that and say, wow, this is, maybe I'm developing this new way of doing, a new workflow, a new process. But now I've seen kind of how this work actually happens. Is that going to really inform how this workflow is going to be able to be enacted?
Yeah, no, that's, I think, oftentimes maybe some of those workflows or those processes or protocols are written by people who maybe don't have that opportunity to be on the ground and see whether or
That's
not
right.
they're effective. Like you had said, like with the tent, there was a tent that was set up with to house some of the supplies, and it was
Yeah.
left there, and
Oh,
so it
yeah.
was moved.
Actually, yes, I think our tent was stolen. And we did see it. It was over there and somebody was living under it. And yeah, okay, you accept that that could happen. So if you don't want that to happen, what's your plan B?
Yes, yeah, and so have a plan B.
Yeah.
Well, thank you so much, Connie, for
Okay,
for for
my
joining
pleasure.
for joining this conversation. And I think
Sure.
it's really supportive for the students that the Island Health has also been really supportive in the public health program for practicums and
For
those
sure.
kinds of things too, and not just public health. I think the nursing program too. So
Yeah, we have a lot of students come from the nursing programs, the various nursing programs, and really happy to support other, not only nurses, like people who are doing health studies also come.
yes, you've been very supportive of my health studies too.
Okay, so I guess we'll
Okay.
sign off.
Yeah, here I'll hit pause. Oh, there we go. Okay. I'm hitting pause. Thanks, Connie. Don't hang up though.
Oh, okay.
Okay.